टेस्ट हिमांशु हिमांशु एलईडी पे डाल पाओगे स्क्रीन को? मनीष, हिमांशु को फोन कर लो एक बार।
Namaskar, everyone, and wishing you all a very pleasant afternoon. In fact, it's also a pleasant evening for on behalf of Health, the Department of Health Research under the Ministry of Health and Family Welfare. To this half a day international symposium on HTA health technology assessment, translating knowledge and best practices for policy into policy, for evidence informed decision making in the healthcare sector, for universal health coverage. This is an event which is being organized in collaboration with IDSI, the International Decision Support Initiative. As I welcome all our eminent speakers who are present with us here physically and also virtually, and all the delegates and the participants, would like to apprise you that this is going to be close to a 2.5 hours event we have. And the way we have structured is that shortly we are going to be joined by our Honorable Minister of State, Health and Family Welfare. She joins us, Dr. Bharti Praveen Pawar. And we also have Professor V.K. Paul joining us. Along with that, we also are going to be joining the other health experts joining us. Professor Balram joins us. And the first session, as we take it, this is going to be close to 1 hour, where we have more of our Indian policy makers. They are going to be sharing their views, and healthcare experts sharing their views and their perspective on HTA. The second session is more towards sharing the learnings from our international speakers, as HTA has been adopted and implemented in some of the countries. So those are the best practices and learnings which are going to be shared in the second session. And if you're good on time, we should be closing by 5 o'clock. So that's how this entire 2.5 hours are actually planned. We're just waiting for our Honorable Minister to be joining, and she's going to be here anytime now. And then we're going to be starting with our sessions. So, welcome to everyone. The people who are present with us, just requesting you if you can have your mobile phones on the silent mode or on the meeting mode, please. Just ensure that you keep wearing your mask, maintaining social distancing. For the people who are joining us virtually, our virtual speakers, requesting you to have your mics on the mute mode. But just a little before speaking, if you can just put your mics on. But yes, your cameras, we would like to request you as you speak, please have your cameras also on, so that the audience here can have a view in of you as you address the August gathering. So we'll just, as I said, we're just waiting for our dignitaries to arrive, and then we should be good to start. Joining us, as I mentioned, is Dr. Bharti Praveen Pawar. She's the Honorable Minister of State for Health. Professor V.K. Paul, Member Niti Aayog. Professor Balram Bhargav, the Secretary DHR and Director General ICMR. We also will be having Dr. Somsak Chunharas, the President, National Health Foundation, Thailand, and Dr. Javier Guzman, Director, Global Health Policy Center for Global Development. Along with them, we have Ms. Anu Nagar, the Joint Secretary, Department of Health Research, and Ms. Geeta Narayanan, Joint Secretary, Department of Health Research. These are the distinguished dignitaries who are going to be part of the first session, close to 1 hour, which we have. Just also request to all our eminent speakers who are going to be joining us virtually. As I mentioned, we request you to put on your cameras as you address the August gathering. But in case you face any bandwidth problem, in that case, you're requested to keep your cameras off with your mics on, so that we can keep getting your expressions and your views. Thank you. And just to once again apprise everyone that as we start with our session, we have several union and state secretaries joining us, directors of the National Health Mission, the chief executive of state health insurance agencies, the directors of ICMR Institute and DHR Regional Resource Center, various industry representatives present with us, and the researchers and the academicians. So they're close to some, we are expecting physically close to some 50 to 60 delegates and participants who are going to be physically present, and some 450 are going to be joining us online. And this is a program which they're connecting with us through YouTube. So this is a hybrid event which we are organizing. As we all understand that the threat of corona, or now Omicron, still exists. So just keeping that in mind, we have many of our international speakers joining us virtually.
ये तो पता
Ladies and gentlemen, we welcome Professor V.K. Paul, Member Niti Aayog, Professor Balram Bhargav, Secretary DHR and Director General ICMR. I also invite Dr. Somsak Chunharas, the President, National Health Foundation, Thailand, Dr. Javier Guzman, Director, Global Health Policy Center for Global Development, Ms. Anunaga, Joint Secretary, Department of Health Research, and Ms. Geeta Narayanan, Joint Secretary, Department of Health Research, to please grace the dais. Our honorable ministers are going to be joining shortly. But we begin with the event. So namaskar once again, and it's a pleasure and delight to be greeting you all and welcoming all our eminent guest speakers and all the delegates and participants joining us here physically and also virtually. Welcoming all of you in the International Symposium on Health Technology Assessment, Translating Knowledge and Best Practices into Policy. As I mentioned earlier, this is an event which is being organized in collaboration with IDSI, the International Decision Support Initiative. Now, before our health experts take center stage, I will just like to take a few minutes to set the context of the day, and then we have our eminent health experts who are going to be sharing their views and their perspective. Now, ladies and gentlemen, as we understand, HTA is a multidisciplinary assessment process which is intended to act as a bridge between the world of research and the world of decision making. And it is intended to make the decision making in the healthcare sector more informed, more evidence based, and its methods and practices are already being implemented in various countries like UK, Canada, Latin America, England, and also in Thailand. As far as India is concerned, as we all know that India is working towards achieving universal health coverage and making its healthcare more affordable for its people, more equitable. And towards that, it is being considered as an important tool. As far as the journey of HTA in India is concerned, it started in 2017 with a workshop which was organized by the Department of Health Research and ICMR and IDSI. And we have been able to make considerable progress in this direction since then, but still the understanding about HTA and its applicability still stands very limited. And also I think we all understand that a country like India, vast country like India with a very complex and vast healthcare system, there is still a long way towards ensuring systematic priority setting. So as we go out in the day, through this conference, through this symposium, we will try getting a better understanding about HTA, what HTA is, what is its need, utility, application for the clinicians, for the researchers, for academicians, for our healthcare workers, for the bureaucrats. Second, we are going to be sharing the learnings from the various jurisdictions where this has already been implemented. So they are going to be sharing their experiences, their best practices, their learnings with us. So we have various countries who are going to be sharing their experience. Also, as we mentioned, that the journey of HTA started in India in 2017. So we are also going to be having the examples and case studies which are going to be shared by the user departments from the central and the state governments. They share their experience, and we share with you the work which has been done by HTA India. And of course, if there are any queries, we are going to be taking those. Any myths related to HTA, we are trying to clear that through this symposium. As I mentioned, the first session is more we have our policymakers who are going to be sharing their views and perspective. The second session, we have more our international speakers who are going to be sharing their learnings and their best practices. And in the second session, we are also going to be taking questions from the audience. So the audience are requested to kindly post in their questions in the chat box, those who have joined us virtually. And those who are physically present with us, if you can just pen down your questions and hand it over to us, and we'll take it in the second session at the end of the second session. So with that, I would like to once again welcome everyone, and to set further the conversation, I would like to request Srimati Anu Nagar, Joint Secretary, Department of Health Research, HTA India, to kindly brief us about HTA India and also for her words of welcome.
Thank you. A very good afternoon to all. Our chairperson of the HTA board and member Health Niti Aayog, Dr. Vinod Paul, our secretary DHR and DG ICMR, Dr. Balram Bhargav, our special invited guests, Dr. Javier Guzman, Director, Center for Global Health, Dr. Somsak, Advisor to HITAP Thailand and former Deputy Minister to Public Health Thailand, our online speakers, Sir Andrew Dillon, founding member of NICE, Professor Stephen Jan, co-director, George Institute of Global Health Australia, Professor Carol, advisor NICE UK, Dr. Tessa, coordinator from WHO Geneva, my colleague on stage, Ms. Geeta Narayan, and distinguished guests. It is my privilege and pleasure to welcome you all to this symposium on HTA. I welcome our chairperson of HTA board, Dr. Vinod Paul, to this event. Sir has always guided us and made ourselves to improve further. This huge vaccination success in India has motivated us to organize this hybrid event, which is like a new normal now. I thank Dr. Javier and Dr. Somsak for traveling all the way to India. I again welcome all the dignitaries on stage and all the participants present here and online to this event. Now let me take you through the journey of HTA in India. Next slide, please. Where is it? Okay. So our National Health Policy 2017 envisages creation of HTA agency in the country. In April 2017, HTA-IN was established under Department of Health Research. Our 119th Parliamentary Standing Committee in March 2020 also talked about strengthening of HTA in India. Working group of ministers on health formed during the pandemic in 2020 also recommended establishment of a central HTA agency. In June 2021, HTA became a scheme of DHR. So our structure of HTA in India, the highest body is Medical Technology Assessment Board. And then there are technical appraisal committee. It is headed by Dr. Sundaraman and it has various experts. There are technical partners and resource centers all over the country. Based upon their expertise, HTA topics are allotted to them and the secretariat coordinates all the activities. In this time period, we've been able to complete about 30 studies and there are about 40 studies ongoing and we have tried to touch almost all the topics. In medical devices, we've been working on intraocular lenses, the safety engineered syringes and the neonatal devices for hearing. On the health programs, we've been working on cervical cancer screening of diabetes and hypertension, and then screening of hepatitis B and C and TECO program in Gujarat. These are some of the topics that we've provided HTA guidance on. On the diagnostic devices, we've been working on TrueNat, RT-PCR kits, the pulse oximeter. This was done even before pandemic started. On the guidelines, we have tried to work on the Europol guidelines, which is the biggest study in the world on this subject. We also have guidelines on quality check. And then on the drugs, we've been working on the contraceptives and on the cancer drugs. In surgical interventions, we've been working on the cardiac surgery pathways and surgical interventions on gallbladder. On point-of-care devices, we have recommended point-of-care devices to the health and wellness centers. On the health benefit packages, this would be our biggest contribution that we have contributed to the Ayushman Bharat scheme of the government. We have also been supporting government in pandemic support. We've been doing costing of the testing kits as well as next generation sequences. We've done costing for this. All these evidences would be put to best use when they are actually utilized by the various state governments and central governments, and we've tried to liaise with both the governments through various consultative workshops. These are some of our decisions that have actually been implemented. For example, in therapeutic use, the safety syringes have been recommended by governments of Punjab, Andhra Pradesh, and they are also a part of our national hepatitis guidelines. Our guidelines also have found way into the national cancer screening guidelines. Maharashtra and Karnataka have kind of introduced Implanon, a contraceptive, as a part of family planning program. The guidelines of RCH have also included our recommendations on postpartum hemorrhage in India. Our studies are also finding way into the WHO documents now. Like I said, the most significant contribution has been that the costing of healthcare packages that we've done have been used for the Ayushman Bharat scheme, and 855 packages have been accordingly removed, and now we are moving into the phase 3 and revising more packages. To ensure that our HTA guidelines are scientifically robust, so we are trying to work on the guidelines also. We have a handbook of health costing system. We have process manual and quality check guidelines and other such guidelines. We also have a national health system costing database ready. This will be our baseline data produced for the first time in the country, and it will also help us make rapid HTA reports so that not much time is utilized in the preparation of these reports. With this, I'd like to thank you and also bring to your notice that we have been trying to publish all these HTA studies nationally and internationally so that they can be utilized by others. Thank you.
Thank you, ma'am, for taking us through this journey of HTA, the work which is being done, the vision and mission it has. And now I would like to request Professor Balram Bhargav, the Secretary of DHR and Director General ICMR, for his views on institutionalizing HTA in India. Ladies and gentlemen, Professor Bhargav is a very revered personality of the healthcare sector who's also been conferred with one of the highest civilian award, the Padma Shri. He is the Professor of Cardiology at AIIMS, New Delhi, and also serves as the Executive Director for the Stanford India Biodesign Center, School of International Biodesign. He speaks to us on institutionalizing HTA in India.
Thank you so much. So dignitaries on the dais, guests from abroad, our beloved chairperson of the HTA board and Minister of State, Dr. Vinod Paul, preliminaries in the audience, people who have joined virtually, thank you for joining for this important meeting. Yeah. So I just present 4 or 5 slides regarding the vision of HTA India is for adding value for healthcare, ensuring affordability, encouraging innovation, universality, quality of care in healthcare. Now, the introduction of new technologies and removing obsolete technologies, priority setting for health interventions for efficient utilization, value addition to indigenous technologies, and how do we get them into the system faster, streamlining medical reimbursement, and it is an enabler for quality enhancement in the healthcare delivery system and health governance. So we have an e-framework for this, which includes the individual nodes, networking, and enabling environment, a capacity of human resources, strengthening in the regional centers, the 17, we're trying to increase that to 28, central and state government health departments networking, and also ensuring that people are not working in silos. Because health financing could be one, health ministry could be another, PMJ packages could be another, then economic analysis could be another. The important thing is that through this HTA board and through the HTAN, we will try to connect all these stakeholders and also ensure not only cost effectiveness, but also ensure that technology is also produced together with the need of the country. So prioritizing that as well would be an important agenda. So long-term and short-term trainings we have an MSc Master's course in Health Economics and Technology Assessment, and we have trainings at regional levels. We are strengthening the resource centers and technical partners, and I think the MTA board has already been talked about, the Technical Appraisal Committee, the main secretariat which is in the DHR, the user departments, and the resources hubs and technical partners. So at the national level, the stakeholders being national research and academic institutions, associations of pharmaceuticals and medical device industries, private healthcare providers, and most importantly, patient and community groups who will always be informed of what is happening in the world, who will always want the best for themselves, whether it is cost effective or not, whether it is best or not. So that is another area which is important at the national level, networking and transparent communication to these people at the patient and the community level, as well as global best practices and reducing duplication. So the MTA board is an independent body, and there are efforts for getting legislative backing for this, and we are trying adaptive rapid health technology assessment, promoting indigenous technologies, pricing decisions and payer negotiations, complying to international best practices, private sector efforts, and HTA board bill. And now the important thing is that we are in the final phases of preparation of this bill so that HTA becomes an important part of the health stakeholders or the health ministry, so that cost effectiveness is the central pillar around which the whole bill revolves. Having said that, we will have to be very, very nimble. We will have to be autonomous. We will have to be flexible. At the same time, we would have to have some sort of a bill which ensures that these technologies which are inappropriate, overly expensive, not effective, are not utilized, as well as technologies and treatments which are effective, cost effective, and are utilized in the system. So I wish this debate all success and discussion all success today. Thank you so much.
Thank you, sir. And ladies and gentlemen, as we've been saying, HTA is an important tool for the policymakers. I would now like to request Professor V.K. Paul, Member Niti Aayog, for his views and perspective on the need for health technology assessment for policy decisions. As we all know, ladies and gentlemen, Dr. Paul has been instrumental in the formulation of various flagship events of the Government of India, the Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, the Ayushman Bharat, various healthcare centers which are coming up, and of course the Poshan Abhiyan. I request you, sir, for your...
Thank you very much. Good afternoon, respected Professor Balram Bhargav, distinguished Dr. Somsak Chauras, Dr. Javier Guzman, Dr. Geeta, Ms. Anu Nagar, distinguished participants and distinguished faculty and speakers of this International Symposium on Health Technology Assessment. First and foremost, I extend to you warm greetings on behalf of Niti Aayog, on behalf of the Government of India. This is an important meeting in terms of going through the process of thinking, brainstorming, and churning around the issues that surround health technology assessment as an important pillar, important pillar of policy formation and policy implementation. We are early in this journey, but I think we are gradually going beyond the stage of toddlership. As you heard from my distinguished colleagues already, very important developments, very important achievements are there on record. We are maturing as an organization, and we have now the confidence to take this journey to the next level, take this organization to the next level of accountability and enforcement, so to say, or implementation of its products. And that confidence is reflected in our efforts to have a legislation to back the existence of this important technical body in our health sector. There are two very important aspects in public health. One, we must not forget that we are dealing with public money. Public money belongs to the people of India. Public money is precious. It cannot be squandered away. It cannot be used irresponsibly. Even for a good cause, there has to be value for the money that is spent. And the second aspect in public health, in health sector in particular, but even in general in social sectors and even economic policy, is the principle of trust, faith of the people that what the government says, institutionalized information passed on to the people should be taken to be trustworthy. I think the foundation of health technology assessment system, let me call it, is based on these two pillars. It stands for trust and it stands for accountability for the public money and the public resources that will go into providing health care. And in that regard, the key words that emerge as a philosophy for ISHTA, as you already heard, evidence-based. Technologies, products, therapeutics must be evidence-based to the extent possible. Where evidence does not exist, the science and scientific community provides us the way forward to address the challenge in good faith and in good trust. But the underpinning is evidence. Evidence which is unbiased, evidence which is seen through the lens of objectivity. The second element of this philosophy is effectiveness. You have seen in the wake of COVID that many things were heard, many treatments were touted based on no evidence. We now know they were ineffective. But the clamor and environment was created in the face of panic and perhaps also motivated in that sense that several things appear to be making a difference, and they got embraced by the profession and even as organized bodies and committees. So effectiveness is an important part. Evidence tells that it is effective. Evidence says how much effect it makes. And that's a very, very important philosophy, the underpinning. The third underpinning is cost effectiveness. And that relates to the use of public money and also the people's money. Even if it is not coming from the national exchequer, for the moment, let's argue, it's coming out of the pocket of a citizen. And citizen has believed in us through the other pillar of trust that what we are saying is truthful. So we're dealing with the trust and we're dealing with the resources that belong to somebody else. And therefore, we must promote cost-effective treatments, packages, technologies, diagnostics, and care pathways. This is precisely the basis on which this organization and this effort stands. We are very fortunate that we have learned. We are not the first ones to do it. We are standing on the shoulders of others who have done it in other countries, in particular NICE, and in our own region, in Thailand in particular. We are so proud, and in Colombia, that our our fellow travelers in developmental journeys have also fashioned their programs, and we are co-learning and we are adapting the methodologies, the approaches that they have fashioned. So we are happy that I'm very delighted and happy that this symposium, this meeting brings together the South, it brings together the North, the West and the East together to look at how we move forward. The HTA version of India, and for that any other country, has to be rooted in our own realities and our own paradigm and the underpinnings and the beliefs that people of the nation have faith in. Ultimately, we have to make sure that not only the access to treatments and technologies and drugs and procedures increases, but also it is in the best interest of the people. And that's where we are taking forward the journey. I have had a wonderful experience working with a great team at DHR, co-led by Dr. Bhargav. We learned, we improved, we changed, we refined, and I would say this journey is still continuing. But surely we are gradually coming out of, a stage where we were taking early baby steps and now moving into a more mature phase. And I think this particular symposium defines that transition from early childhood to a mature adolescence, if I can say that. I'm very pleased to be associated with it. I look forward to looking at the recommendations in a systematic way, examining them as it comes, and please share your ideas. We would like to embrace the best principles, best experience to make our organization, HTA and India, the very best in the world. Thank you very much, Jai Hind, and welcome, ma'am.
Thank you, sir, for guiding everyone. And ladies and gentlemen, we now welcome our Honorable Minister of State for Health and Family Welfare, Dr. Bharti Praveen Pawar. Thank you, ma'am, for joining us and for leading this symposium. Ladies and gentlemen, Dr. Bharti Praveen Pawar herself is a medical doctor by training, and she's had a very keen interest in working for the improvement of the health status in the country. Also, in her earlier role, she has played a very pivotal role towards eradication of malnutrition and towards the provision of clean drinking water, providing it in the Nasik district. So thank you once again, ma'am, for being a part of these discussions, and of course we look forward to your guidance and your way forward. Ma'am, may I request you to kindly release the video on the very promise of HTA. If I can just request through a remote. This is a short video on the promise and the power of HTA, how HTA can help when resources are limited and there are so many high priority diseases.
Indian healthcare system is complex and caters for the needs of 1.38 billion people. Health system consists of hospitals, pharma industry, health insurance provider, etc. It is constantly under pressure and has limited resources. Every stakeholder has their own perspective on what the healthcare system should prioritize.
I deserve the best treatment available for my health issue.
I know what's best for my patients. Let me decide what treatment is to be given.
Our latest health technologies are expensive but give better results. They should be used by everyone.
Decision making should always be evidence-based and consider value for money.
How can we ensure healthcare is equitable when resources are limited and there are so many high priority diseases to treat?
Ultimately, policymakers need to make smart budget decisions that lead to good quality healthcare services for all citizens and help the country achieve universal health coverage.
A health technology assessment or HTA can help. HTA is a widely accepted multidisciplinary process where a health technology such as drugs, medical devices, or health programs is evaluated for its clinical effectiveness, cost effectiveness, and equity issues. It helps policymakers make evidence-informed decisions that is strategic, transparent, and robust. Health Technology Assessment in India, or HTA-in, is a program under the Department of Health Research, Ministry of Health and Family Welfare, Government of India, which undertakes health technology assessment for the government.
Established in April 2017, HTA-in has completed more than 30 studies and many more are underway. Let us now see an example of how HTA can help policymakers in decision making.
Okay, the incidence of cervical cancer in the country is worryingly high. Treatment for cervical cancer is already offered, but a universal screening program would decrease its incidence. How do we know if it's affordable and how to roll it out efficiently? How can health technology assessment help me to find the right answers? Health technology assessment in India, HTA-in, is the answer.
If I have to launch the screening program, will it be cost effective? Cervical cancer screening is rather cost-saving strategy in the long run. But considering the limited available budget, it should be first rolled out for women of age group 30 to 65 years. Screening by VIA method yields best results. Screening should be done once in 3 years.
Likewise, HTAs can be used to inform a variety of policy decisions, including introduction or removal of technology from a health benefit package, prioritization and design of health programs, efficient budget allocation, costing of health services, strategic purchasing during procurement, drafting of standard treatment guidelines. Altogether, this helps the government in its commitment towards universal health coverage. A strong health system is the foundation of a healthy country. HTA plays an important role in taking India towards universal health coverage. It is health that is real wealth and not piece of gold and silver.
So that is why, ladies and gentlemen, we need HTA, the Health Technology Assessment. As was mentioned, this is an important tool, important process which can help India achieving its universal health coverage and making healthcare more affordable. At the same time, assisting the policymakers and the researchers and academicians in more evidence-based decision making. May I now request our Honorable Minister, Dr. Bharti Praveen Pawar, to please address this August gathering.
Thank you so much, Professor Vinod Kumar Paul, Professor Balram Bhargav, Dr. Guzman, Dr. Somak, Mrs. Anunagar, and all my friends, other eminent experts who have joined us virtually. Namaskar. I am pleased to be addressing this very important international symposium on health technology assessment. It's an opportunity to discuss the global best practices in HTA and for the development of sustainable model of evidence-based decision making through HTA, institutionalization in the country to achieve the universal health coverage. Friends, with the challenge of COVID-19 pandemic throughout the world, governments and healthcare organizations across the globe are focused to respond to unparalleled demand for their services. This crisis is forcing healthcare leaders to rethink the technologies, process, and the protocol to ensure the continuity in the critical services while prioritizing the safety of patients and employees. I think active engagement of all these stakeholders and the multi-sectorial coordinations is needed to identify areas of the work, defining the problem, commissioning in economic evaluation, the quality assurance, and the dissemination of the result and the recommendation for the implementation in healthcare sector. Friends, under this, the able guidance and the leadership of our Honorable Prime Minister, Shri Narendra Modi ji, India is moving goal of universal health coverage by enhancing access to better quality of healthcare services through various health programs, including its flagship scheme like ISHTA Bharat. The efforts of the central government is to work holistically and emphasize on preventive care, while also giving the priority to modern treatment facilities based on the innovative healthcare technology. The government of India under Ayushman Bharat scheme is working to establish about 1.5 million health and wellness centers in the remote areas of the country. I'm also glad to note that our government has launched the landmark Ayushman Bharat Health Infrastructure Mission and Ayushman Bharat Digital Mission this year, based on the foundation laid down in the form of Jandhan, Aadhaar, and Mobile, Trinity, and the other digital initiatives of the government. Ayushman Bharat Digital Mission will create a seamless online platform through the provision of a wide range of data, information, and infrastructure services. Friends, our central government, with active participation of our state governments, has played a key role in designing health policies, program, and supporting the stakeholders with the technical and financial resources. Recent COVID pandemic and outbreak of diseases like Japanese encephalitis, Nipah, made us realize that the strengthening India's public health system is the need of the hour. Strengthening the health system requires a joint efforts of state and the center in prioritizing the healthcare efficiently, using the health resources to gain the maximum health gain for maximum number of people, adoption of quality standards, fulfilling the skill gaps, updating and complying with the standard treatment protocols, and reducing the out of pocket expenditure on health services. Hence, there is a growing need for evidence informed health policies to make correct choice to ensure the effective and efficient healthcare system. Friends, India is now indigenously manufacturing many products of which earlier we used to rely heavily on imports. The government of India's initiative like Make in India and Atmanirbhar Bharat have encouraged many indigenous manufacturers to bring innovating and frugal technologies in country. But sometimes cost of new technologies are very high, so it becomes difficult for the government to decide whether we can adopt a new technology in the healthcare system and how effective will it be to replace the existing technology or the program with the new ones. These type of questions can be easily addressed by health technology assessment process adopted in India under our Ministry of Health and Family Welfare. Therefore, health technology assessment in India bridges this gap between the real world evidence and the policy decisions, strengthening Indian healthcare sector with robust scientific methodology. HTA is one of the tools of evidence informed decision making. Experiences of several countries have shown that HTA had a great contribution in strengthening their health system. It addresses the clinical and cost effectiveness of an interventions and also gives an idea of budget impact, which makes the process of policy decision easier. I happy to note that HTA incentivizes the pharmaceutical and the medical devices industry to produce the technologies and are genuinely innovative, good quality and good value for us. I hope that HTA ensures an equitable, affordable, accessible and high quality healthcare to the whole population with limited resources available. Ladies and gentlemen, we have been witnessing improvement in the indicators of health in India, but there is a long way to reach universal health coverage. To achieve the same, utilizing HTA services is absolutely necessary. I hope this symposium will provide an invaluable basis for high level learning, understanding the HTA importance in healthcare sector. It's a valuable opportunity to learn from the success and the challenges of the other countries on how they are worked towards universal health coverage and utilized the evidence based decision making for setting the national practices priorities. I congratulate the Department of Health Research of our ministry for organizing such a unique program, and I hope the outcomes of this discussion will help our country, which is on the path of achieving the goal of health for all. I sincerely thank you all for joining, and my best wishes for your further deliberations in this international symposium. Thank you. Jai Hind.
Thank you, ma'am. Thank you for your inaugural address and your views and perspective on the very promise of HTA. And as you said, that under the leadership of Honorable Prime Minister Modi, India is aiming to achieve universal health coverage and making healthcare more equitable, more affordable for its people. This stands as an important tool. Looking into these new technologies is definitely going to be very fruitful. Thank you, ma'am, for guiding us. Ma'am, may I request you now to please release two publications. There's a first book is on the development of health-related quality of life value set for India. The Indian EQ 5D value set. This book contains the health-related quality of life estimates for the Indian population. We are pleased to share that India has prepared its own EQ 5D value set, which is a key input for undertaking any HTA study. By providing the Indian value set, this book will serve as a much needed and much awaited resource for the healthcare priority setting. Our Indian EQ 5D5L value set is prepared as a result of the largest preference-based health valuation study of the world and the first such study in South Asia. The health-related quality of life values for all the possible disease states are contained in this book. The second book which we have, if I can, it's already been released. If I can just request all of you to also for the photograph. Yeah. This is the HTA policy briefs. This book, ladies and gentlemen, is a compendium of all the HTA studies which have been commissioned by HTA India in our country. The key messages of all the HTA studies are presented in this book in a very lucid and comprehensive way. It also informs the readers about the pertinent health issues which have been brought to HTA India by different user departments, their possible policy options and evidence-based recommendations. And this book presents the vital research findings in easy to understand language. It is therefore, ladies and gentlemen, a one-stop reference to policymakers to assist them while making important health policy decisions. So with that, we come to the end of this first session, and we are going to be moving into a second session where we have our international speakers who are going to be sharing their best practices, the challenges which they have also faced towards the adoption of HTA. It's going to be a lot of learning listening to them. So I think we continue with the session. May I request the other speakers to please take their seats in the front row, and request both our international speakers to remain with us on the dais. So once again,
I would like to thank Honorable Minister of State, Madam Bharti Praveen, for joining us here and blessing us with her words of advice. I also thank Dr. Paul for being here with us and always guiding us in HTA. I also like to thank Dr. Bhargav, our secretary, our mentor and guide. Thank you.
So thank you once again to our Honourable Minister, her guidance, her views to us, and of course, thank you to Professor V.K. Paul. Thank you, Professor Balram. Ladies and gentlemen, as we mentioned, this is a symposium which is being organized in collaboration with IDSI, the International Decision Support Initiative. And this is a global initiative where they have been working towards creating awareness about HTA, and then further extending, assisting technical assistance to the policymakers and the HTA agencies, to the academicians and researchers for the global institutionalization of HTA in various countries. So we thank them for all the support, and as I mentioned, we now move into a second session, and I would like to invite Dr. Abha to please take center stage and for the further proceedings of the session. I hand over to her.
Good afternoon, everyone. So looking forward to the second session, we'll be looking at international best practices on setting up HTA systems. The first speaker for today is Sir Andrew Dillon. Sir Dillon is the founding chief executive of NICE, the National Institute for Health and Care Excellence in the UK, and he remained the CEO for 2 decades. He is currently the chair of the Life Science Advisory Board of NICE. Sir Dillon graduated from the University of Manchester in 1975. He went on to hold a number of senior management positions in the UK Health Service, National Health Service, including being the general manager of the Royal Free Hospital and chief executive of St. George's Hospital. Both are academic health centers in London. After that, he was the chief executive of NICE for 2 decades and now continues to work as an independent healthcare advisor. So I'm handing it over to Sir Dillon for his presentation.
Hi there.
Yes, requesting if you could increase the volume to the organizers. Yes, please go ahead, sir.
Right, thanks very much. Good afternoon, everybody. Thank you very much for inviting me to contribute to your meeting. I've been asked to talk for a few minutes about the reasons for NICE being established in the UK and on the way it operates now. The NICE was established in 1999 to provide advice to the NHS in England and Wales. There'd been local efforts before that to use evidence to inform decisions about the use of new technologies. But it wasn't until NICE was established that this was going to be done at a national level and in a systematic way. And it was set up because at that time in the NHS in England, there was a slow uptake of new technologies and practices in the NHS. There was widespread variation in the nature and quality of care. So you could be living on one side of a city or a town and get access to a new drug, and somebody else living on the other side of the city or town who didn't have access to that drug. So there were real inconsistencies in the availability of new treatments and services. There was also a commitment by a new government that had been elected just a couple of years before NICE was established to improve the quality and the range of care, and also a commitment to make a significant reinvestment in the NHS. The plan at that time was to grow the share that the NHS had of gross domestic product from about 6.5% to about 9% of GDP. So what were the government's expectations of NICE when it was first established? Well, what it wanted was a national authoritative source of advice. It wanted something that would be respected by health professionals, trusted by patients, and understood by the wider public. That was the most important thing it needed. And then it wanted the organization to look not just at the clinical effectiveness of new treatments and existing treatments and forms of practice, but also about cost effectiveness. So it wanted to understand the value for money that the NHS and patients were going to receive from the introduction of new technologies. It wanted the new organization to be inclusive and consultative, so it wanted it to make sure that it involved everybody who was going to be affected by the decisions that it was taking, health professionals, patients, and also life sciences companies for the aspect of NICE's work, where they were looking at new drugs and other kinds of technologies. It needed to be independent, so it needed to be seen to be independent in government. With great respect to our politician colleagues, it's essential in the application of science that there's a clear distinction between the political policies that have been put in place to advance healthcare and the detailed decisions about what the science tells us about the use of new technologies. It needed to be efficient, and it was also going to be a service not just for the NHS, but also for the wider public. So NICE had to be able to write its guidance in a way that could be understood by ordinary citizens, not just by health professionals. But of course, pretty quickly after NICE was established, it became apparent that in addition to the government, there were lots of other stakeholders who were also going to take a close interest in what NICE was doing. The wider patient community and the organizations that advocate for them were going to be involved. They're really keen to understand the impact that NICE was going to have on the availability of treatment. The life sciences industry was very interested because, of course, for the first time, NICE was going to subject their products to the kind of scrutiny that they rarely experienced before, certainly in the UK. Health professionals, of course, because NICE was going to some extent, was going to inform and maybe even constrain some of the decisions that they might want to take in terms of their professional practice. Those who got stewardship responsibility for money in the healthcare system had a deep interest too, because NICE's recommendations, although focusing on value for money, were nevertheless going to drive the uptake of sometimes expensive new technologies. Politicians, an important community for NICE to recognize because of their responsibility for explaining the way the NHS as a publicly funded organization was performing. And then, of course, the media, for whom NICE was going to be an important and enduring story. The answer to this question may seem obvious, but it really is important to be clear about the value of using evidence to inform health policy. In the UK, it hasn't always been the case, and it still isn't. But for me, the most important reasons are that evidence helps decision makers focus on outcomes that matter to patients and those that are likely to offer the largest health gain. It helps to secure equity of access to and the efficient use of resources by improving both allocative and technical efficiency. It resonates with the basis on which many health professionals practice. Most health professionals are trained to use evidence to inform their decision making. And as patients, of course, most of us like receiving, rather like the idea that there's some underpinning evidence to the recommendations that health professionals make about our care. And finally, it enables decisions to be better explained and justified to those who use and, of course, pay for the health service. 20 years after it was established, NICE now produces a range of guidance for the health and care system. on drugs, medical devices, diagnostics, and now increasingly new digital technologies. It produces more comprehensive sets of recommendations on diseases, whole diseases and conditions, and the care pathways associated with them. But it also produces guidance for public health and social care professionals, because in those areas, evidence exists, and it's important, just as important as in clinical practice, for that evidence to be used to inform decisions taken in that part of the health and care system. And it enables NICE to produce comprehensive sets of recommendations where the interface between the health system and the public health system and social care needs to be managed carefully. Although there are some differences between its programs, the principles that NICE uses to produce its guidance are pretty much the same in most cases. The most important thing that NICE does is to pull together a comprehensive evidence base. It does that sometimes by commissioning independent systematic reviews and independent economic models, but it also sometimes asks life sciences companies to produce their own evidence dossiers that NICE scrutinizes in order to make judgments about new technologies. The evidence also needs to include the perspective of patients and health professionals who are working in the system. And NICE also needs to understand the potential budget impacts of new technologies and forms of practice. That evidence is then put in front of an independent advisory body. And the independence of that advisory body is absolutely critical to the credibility of the recommendations that are produced. It's important that those who are making decisions, both professionals and patients in healthcare systems, know that the guidance that they're using, when they do use guidance, is produced, that the perspective that's brought to bear is simply one of understanding what the science says within the framework that those decisions are taken. The advisory committee's draft recommendations are subject to widespread and genuine consultation, so the advisory committee will respond to reasoned argument if it needs to change its recommendations. And then once the guidance is finalised, it goes out into the healthcare system with the support of the NHS, those who are running the NHS, with the support of the government, and hopefully with the support of everybody else who's been involved in producing the guidance. And then periodically, NICE, through an evidence surveillance process, makes sure that it keeps its recommendations up to date. Producing the guidance, I used to think, was the easiest part of the process of the whole business of evidence informing practice. Publishing the guidance is simply the start of the journey for making change in the healthcare system and helping to improve outcomes for patients. And my colleague Carol Longson is going to say something a little later on about the whole way in which NICE guidance influences the healthcare system and the wider life sciences ecosystem. So just coming to a conclusion, and to conclude my remarks, what have we learned over the last 20 years in the UK with NICE and its colleague organisations in Scotland and Wales and Northern Ireland? What conditions need to be in place to provide the best possible chance for a health technology assessment initiative to succeed? Well, in my view, it needs broad support for using evidence to inform decisions. Unless there's widespread support for the initiative from people working in the healthcare system, from politicians who've got that stewardship responsibility for the healthcare system, and those who are using it, it's unlikely to be successful. The initiative has to align with the priorities and ambitions of the health and care services. So in relation to establishing value for money, it's important that that judgment about value for money is aligned to the relative wealth of the healthcare system at any one time. It's essential that there's the capacity to generate and to use a comprehensive evidence base. And there needs to be, I think, a genuine commitment to engaging with stakeholders in developing the guidance. So consultation, exposing draft recommendations to the scrutiny of the wider community of people who've got an interest in it, needs to be real, it needs to be genuine, and it needs to be systematic. There need to be transparent and contestable methods and processes for developing the advice, so people need to know how the organization goes about getting the evidence base, interpreting the evidence base, and then formulating those recommendations. And then finally, and just to conclude my remarks, it's absolutely critical that once the guidance has been developed and once it's been published, that there's support to help to get the guidance implemented in the healthcare system. So once again, thank you very much for inviting me to join this event. I'll look forward to contributing to the panel session a little later on. Thank you.
He has directed several offices in his Ministry of Public Health, focusing on international health, health policy, and health system research. He has also pioneered a team on health economics that has led to various reforms initiatives which over the last 30 years. This has developed into a large number of Thai universal healthcare system, and the ISHTA which is there in Thailand is already well known for the HTA that initiatives that have been taken, and the evidences that ISHTA has supported in the health minister taking in decisions for the policy making and for universal health coverage. Over to Dr. Somsa. Thank you.
Thank you very much, Kavita, and honorable guests and international speakers and dear friends in India. It is indeed a privilege and honor for Thailand to share our experiences. Having listened to the ministers and Dr. Vinod Paul and Professor Baram, I'm sure that we will be learning a lot from India. You are going to the exponential growth and exponential impact phase with the establishment of HTA. But allow me to focus on one point which I have been asked, which is how do you create more value for money, which is definitely the concern. It's not only cost saving. HTA could do a lot in terms of making sure that the UHC, the health system, is updated, respected, trusted by the public. Why make sure that it is affordable? Just give you a short history for those of you who might have heard the word HTA, because in Thailand, at least, we have been doing this ever since the mid-80s, before the UHC. And before that, it was mostly tools for decision making of clinicians. And of course, we try to make use of that in guiding policy decisions in terms of procuring big pieces of equipment, For example, in trying to procure proton accelerator for radiation therapy is a good example. We did go through some HTA, but that was very scattered and ad hoc until, of course, when we have the UHC. When we enter UHC, things change. There's a much more important demand to make sure that the so-called benefit package is not fixed, but dynamic and updated with the new technologies. And as you have listened to Professor Baram, people have lots of expectations about new technology, wrongly or rightly. That will be something that is worth considering. But the fact is that, as Sir Andrew pointed out, you have to make it in accordance with your health system affordability and reality. So that would be the challenge. So after the UHC established in Thailand, we have not yet have the HTA formally established until 2007, when we have Dr. Yot. I have to mention his name because he has been very instrumental for me as a so-called evidence user policy maker. We cannot have evidences and good process of engaging stakeholders if we do not have a team, a mechanism to carry that forward. So I hope that your HTA institution would be like that. Then I'll share with you what we did, the more detailed operation. The first one would be about the policy channel through which HTA contribute to UHC policy. And then, of course, some of the so-called secret therapy or recipe, and then some overall conclusion. As you can see, there are at least 4 things that HTA team has been trying to do. One is on medicine or therapeutics, diagnostics. And then, of course, vaccine is another separated thing because they are more public goods as compared to medicine, which could be a bit more market-driven. But then, of course, the more important thing is intervention, the non-pharmaceutical kind of things, public health intervention programs, things like that. But also, we do the public policy evaluation, which would lead to different kind of decision-making, essential drug list, essential vaccines, and of course, benefit package development. And this, within the Thai context, has been scattered in different departments. So it's not only contributing to the UHC program, but it's contributing to other parts of the so-called health system operation as well. And of course, this is just a summary that when we do the so-called pharmaceutical analysis of HTA, we have some threshold, but we don't just give yes and no answer. Of course, for those who have fulfilled the criteria of cost effectiveness, it's easy. But for those who exceed the threshold, we have different processes built in. For example, we have price negotiation as one of the examples, but we also have exceptional consideration for those pharmaceuticals which are very important to improve health, but may not be that cost benefit. So we come up with different kind of so-called cost sharing schemes. In terms of cost saving, these are just examples of how different pharmaceuticals underwent HTA have led to so-called cost saving. You have the market price and you have the revised price even before or after. I'll tell you a little bit more about before and after price, consideration. But these are some of the saving. In total, it was estimated over the last 7 years we have saved billions of US dollars in terms of pharmaceutical within the UHC program itself. And as I said, it started about 6 years after we have the UHC. And these are some preliminary figures. Of course, this doesn't happen as a technical process. It happened as a political process, if you like. For example, in terms of a drug, we engaged the experts from the very beginning. So the first arrow pointed to the fact that we involve groups of experts, technical experts, specialists. So it's not only the crazy health economists who have been doing their own job. But the second part, of course, is a fact that we could bring in competencies and approach of economic analysis. And the economic analysis and many other things came in. And of course, the last thing is the final decision maker. In this particular case, is a subcommittee attached to the Thai FDA. So the Thai FDA is responsible for this particular process. And HITAP, being the HTA agency, ensure that the process is participatory, transparent, and accountable. Of course, the final decision rests with the policy maker. And as I told you, the subcommittee took up many initiatives, including price negotiation and the decision to include some, which might not be that cost benefit, but with potential new cost sharing model. And then, of course, as I say, it doesn't make the final decision. As HTA, we don't have the ability to do that, but we provide information that lead to proper intervention and decision later. On the price intervention triggered by HTA, as I mentioned, in the process of doing HTA, we have the so-called prior price submission. In other words, pharmaceutical companies could decide on which price that they believe they would charge if it is maybe adopted. And that has managed to, do some kind of self-reflection on the side of the pharmaceutical companies or the private sector to decide which price to make sure that it is more cost benefit. But as I say, after that, we have price negotiation, and we even have some special arrangement for certain drugs, such as the one for gouty diseases, which is a rare diseases, and it's very costly, but we cannot negotiate the price to be much higher. And we have, you can read about that, but basically it's about making sure that there's a fair share of so-called benefit and risk among the policy makers and the pharmaceutical company to make sure that the drugs will be made available. Now to the benefit package of UHC. in terms of the UHC benefit package itself, there's a subcommittee on benefit package within the UHC, the NHSO, which is a strategic purchaser. In your case, it could be NHA, a benefit package subcommittee, who will request HTA analysis. So it will be a lot of so-called interaction. But basically, again, back to the point that you need to have prioritization. You need to make sure that whatever you are going to assess actually falls within some expectations, some potential demands from all parties, including, of course, from the technical perspective. And then you do the analysis, and then you have the so-called discussion among the policymakers. I'll give you two examples. There are so many examples. For example, we did tackle on the so-called dialysis demand for the patient with renal failure. And we came up with the conclusion about using PD first, peritoneal dialysis first, not hemodialysis, for those of you who might be technical and knowledgeable about the possible intervention. I just wanted to show that, the kind of analysis that has happened within HITAP has been also translated and learned with our colleagues in Indonesia and the Philippines, because they have adopted different strategies without going through proper HTA. But the more important thing is that in doing the HTA, we not only do economic analysis, but we do also system analysis and system design for better access for rural population. So the PD first policy take into consideration the fact that PD would be made more accessible to the rural population rather than having to ask them to travel all the ways to the hemodialysis center in big cities. So I just wanted to highlight the fact that HTA is not only about economic analysis, it's also about system analysis, system design, to make sure that the delivery and the implementation would be there. Another example is that we also evaluate existing program, existing policy. This is about helping the disabled. Government made a lot of investment through different major health insurance program to help the poor. But in detailed analysis, we found that there are lots of room for improvement. We could even actually potentially save about 4 billion baht annually if we change the way we implement the program, we manage the program, to make sure that whatever we provide will be really beneficial for the people. Now come to the secret sauce. I think it's very simple. I'm sure that you are also trying to do the same thing, which is to make sure that evidence is linked with decision making. But I wanted to emphasize the fact that you need good processes. If you don't need good processes, it's not only generating evidence and then give it to the decision maker. It is not that easy. And of course, within this particular so-called three interactive processes, you need to make sure that the process is transparent, participatory, and accountable, and credible. As Dr. Pinod Paul has been mentioned, you need to create trust at the end, because you are making a very difficult decision, to affect people's health, people's choices, people's possibilities. So you need to be accountable and transparent. You have to make sure that the process is participatory. On the other hand, you need to build up capability. And capability means both ways, researcher as well as decision makers. And you have to have all kinds of things to make sure that, many of these things are accountable. And we have some kind of a interesting analysis on participation of stakeholders. You can read through the slide, but the point is that you need to have a process that engage multiple stakeholders rather than just the technical processes. I could not emphasize enough for the need to engage stakeholders, and you need to devise different steps in the process. And of course, in terms of human resources, as I mentioned, it's not only about researchers, it's not only about the existing technical people, but you have to educate the younger generation through curriculum. You have to also have workshops with the policymakers, with researchers. But more importantly is the fact that you need to try to make sure that decision makers and general public is part of the human resources strategy. So if you look at the lower right-hand corner, and we did that through social communication. So you should make sure that you have effective social communication, because that is the way where you try to merge the expectation of the public as well as the interest of the policymakers. Technical people can tell policymakers whatever they like, but unless the public agree. So you need to do that, and of course you need to build up health research infrastructure, which I'm glad that many of the things have been done all the books and things like that, all the methodology and things like that. So to come to the conclusion, to me, I think the Thai experience has shown that HTA can certainly provide a sustainable pathway, and then emphasize sustainable, by making it more responsive as well as cost containing, value for money again. But the second part is that you need a systematic process to make sure that the evidence and policy linkage is there. And as I have described, you need some different way from the conventional thing, but it's definitely important for decision support. And the last point is that it certainly, if you do it well, it will add value for the people and also add value for money for the government, because as Dr. Middle Paul mentioned, it is public money at the end, and you need to make sure that you can be accountable and show the people that you have been given all your great consideration to how you spend public money rather than just lavishing it. Thank you very much.
We thank Dr. Somsak for a very insightful presentation which we heard, and we also saw how the government of Thailand is working towards universal health coverage with all the evidence that is being produced by the Health Technology Assessment team. Thank you so much, sir.
Our next speaker is Dr. Javier Guzman, and he will be speaking about the impact of HTA in Latin America. Dr. Javier is the Director of Global Health Policy and a Senior Policy Fellow at the Center for Global Development. He's previously worked as a physician, researcher, analyst, and policymaker in several countries, which includes the United States, UK, Australia, and his own native, Colombia. He's also worked for the Colombian government. He served as the Deputy Director of the Health Technology Assessment Agency in the country. Subsequently, he was the Director of Medicines and Health Technologies at the Ministry of Health, and finally, as the DG for Colombian Food and Drug Surveillance Agency. So warmly welcome you, Dr. Javier.
Thank you very much. It's a pleasure and honor to be here with you. Thank you very much to our hosts from the Ministry of Health and Family Welfare and our fellow panelists. So I'll talk a bit about our experience in Latin America, and I have to say it is work in progress. So I have, I think, a lot of interesting insights and lessons into what worked and what hasn't worked. The first thing to say is Latin America is a region of 20 countries, about 640 million, excluding the islands. I'm not talking about the Caribbean. But interestingly, most countries are upper middle income countries. We still have 4 lower middle income countries and 2 high income countries. And that is important because the countries in the region are really pharma emerging markets, where the pharmaceutical market is growing faster than the overall economies, which creates pressures on the systems to absorb and introduce new technologies. In the region, we had a lot of health sector reforms in the 1990s, and that basically created an interest in health technology assessment and evidence-based decision-making. On one hand, because health benefit packages were being introduced with support from the World Bank. On the other hand, because there were changes, including the change that healthcare is a human right in most countries, included in the constitutions, which also creates another layer of complexity in terms of the ability to say yes, but the ability to say no. And the ability to say no is, how do you basically say to the population that a medicine is not going to be included or is not going to be paid by the system? 10 years of work you see here in this slide, and I want to highlight the regional perspective. So in 2011, the Pan American Health Organization launched the REDETSA network. It's a network of health technology assessment agencies, ministries of health, researchers, and that has been instrumental in putting the health technology assessment conversation in the agenda of policymakers. Now, Interestingly enough, as well, the region has created agencies, departments, and commissions in different countries. The most important one, I would say, is in the early 2010s was CONITEC in Brazil. And that was not the first agency created in Brazil, but it has been the most important one. I'll talk a bit about that. And it led the way. Other countries, including Colombia in 2012, Chile, Ecuador, Argentina, have created these units. In 2017, the region launched a database of all the different health technology assessment reports. It's called BRISA. It now has over 2,000 reports. And that has been very important for the region to understand what has been done, what has not been done, what outcomes have been found in the different reports, and use that information to avoid recreating the wheel. What have we learned? So a few lessons, a few important insights. The first one is the entry points have been different. The ways, the goals that have been sought by introducing health technology assessment have been different. So one is the health benefit packages in terms of determining what's in and what's out, what's covered and what's not. But also other countries have approached HTA with different angles. One is price determination and procurement. So countries like Ecuador, for instance, they use HTA to determine the price they will pay for medicines that are not included in the benefit package. Or in Brazil, for instance, the price is determined as soon as the medicine enters the market. And interesting, in a lot of countries, the entry point has been quality clinical practice guidelines, and what Dr. Somsak was saying in terms of how physicians do want to improve practice. I guess what I'm saying is that there's not a single path, different ways to approach the same issue, and it's actually a way to merge it all together and improve care and improve value for money. Second insight is that the agencies and the institutions didn't start with cost effectiveness analysis from the get-go. And that was partly because there wasn't the capacity, partly because policymakers were interested in other questions. So it has been something that has been built over the years, starting with comparative effectiveness, going into budget impact analysis, introducing multi-criteria decision analysis to finally reach, economic analysis and cost effectiveness analysis. And that, I guess, all I'm saying is, it's not a linear path, and it needs to be built over the years, and it takes a lot of time, effort, and leadership, of course. A lot of capacity has been created. A lot of assessments have been conducted. As I said, in the past 10 years, the BRISA network accumulates 2,000 reports. But that's not enough. Creating capacity and conducting assessments is only a part. And unfortunately, the translation, the implementation is not guaranteed. So the use of the evidence, acting on the evidence is not guaranteed. And in that regard, I was talking this morning about the need to incorporate in the legislation clear provisions for the evidence to be acted upon, and clear provisions for the processes to be really explicit for this evidence and for this report to be used. A good example of success is Brazil. So that's the only place where the reports are, the HTA and the reports are compulsory in nature. And this is what they've done in the past 10 years. So CONITEC has done 613 assessments, about 60 assessments per year. And out of those, about 60 are positive recommendations. You see here how the bulk of the work has been medicines, but also increasingly procedures, medical devices, and other health technologies. Three more lessons that I wanted to highlight. The first one is time and capacity are of the essence. It's not just to jump straight into economic evaluation from the get-go. As I said, building blocks were put in place and have been put in place. And I see how the building blocks like the costing database that the Department of Health Research has put in place is a great starting step, also the EQFID as well, also the network of centers. I mean, these are all building blocks that are needed for this enterprise to be successful. The second, I want to highlight the relevance of the topic selection process. So what technologies go into HTA. We saw the slide from Thailand where they basically have a process to decide. And that's important not just because you are prioritizing the capacity, but also because what's being assessed has an implication on the coverage at the end. It provides legitimacy, it provides a clear arrangement, it provides, a way for everyone to nominate the medicines or the technologies that they want to be assessed. And finally, rapid reviews, I mean, policymakers act upon the evidence if it is available. If the evidence is not available and the assessment takes years, well, it's basically unfortunate, but policymakers will not make decisions with the evidence. And that is, I guess, the importance of introducing regional approaches and introducing rapid reviews or ways to get the evidence without going through a fully fledged HTA process that takes 1 to 2 years. Best practices are important, and it's just easy. What we said, it was easy to write them, but it has been very difficult to implement them. In terms of stakeholder participation, transparency, predictability, consistency, that all is, good on paper, but unless it's actually put into standard operating procedures, put into clear guidelines and methods, it's just difficult to implement. And as I said, cost effectiveness has been used as a crucial criteria, but a lot of policymakers don't want to be or don't want to have a strict rule in terms of a yes and a no, and do want to include other criteria, other dimensions of value. Equity, for instance, the ability to implement, the priority of the health system. So I guess all I'm saying is that is being used in the region, but it has been used in complementing other dimensions of value. And I give you the example here in Colombia where we've put together some criteria to decide what technologies are assessed. So that's basically the topic selection. But 2, we have put in place some criteria to do the appraisal and determine, the outcome of the assessment. And the criteria are important because that provides certainty, transparency, and consistency. Finally, last but not least, I think there's a very nice, important window of opportunity for health technology assessment in terms of the COVID response. We've seen in Latin America assessments and studies in terms of what interventions to deploy. And we know about antivirals, but we also know about vaccines, what type of vaccine to deploy, but also how to deploy them. And we see a lot of possibilities also with HTA of public health measures such as genomic surveillance. And that basically will support decisions from policymakers to invest into areas that have not been a priority in the past. The second nice window of opportunity, which is a very difficult one, is the world is basically in a very difficult situation at the moment. In Latin America, we saw the biggest recession in 100 years with a GDP contraction of 7%. And that basically means we will need to do more with less. And that basically means the decisions that will be made will need to be basically the right decisions, and value for money needs to be there. Also, as I said, the sustainability of the healthcare system is in danger in countries whenever they increase their health expenditure. A lot of new, shiny, brilliant health technologies will come, and there will need to be a process to say yes, but also to say no. Health technology assessment will also play a part in, reaching universal health coverage and maintaining universal health coverage. So, final word is basically, we have a lot of challenges in Latin America. Translating assessments is one. It's not just about producing, conducting assessments and having capacity, but also to demonstrate the value of health technology assessment to the system, to the policymakers, and to society, for it to be successfully implemented going forward. Thank you very much.
Thank you, Dr. Javier. Some very important lessons shared, that we need to ensure that the key building blocks are in place. India has already made progress with the EQ5D study and the National Health System Cost Database, but also important lessons on ensuring that going forward, we always are choosing the right topic, having robust methods, and then reliable adherence to processes to ensure that the evidence that's generated gets translated into policy.
We have the next speaker, Professor Carol Longson. Dr. Carol is Life Science Advisor at NICE and a respected leader in health technology assessment. With considerable achievements in research, public and private sector, she has led NICE Health Technology Evaluation Program for over 18 years. Dr. Carol was an executive director at NICE from 2000 to 2018 and a chief scientific officer at the Association of the British Pharmaceutical Industry from 2018 to 2020. She was formerly president of Health Technology Assessment. She has a long experience in sharing her international knowledge and the impact of HTA on healthcare priority setting. So we would be very happy to hear you, ma'am. Over to you. Thank you.
Thank you very much, and thank you to the organisers for giving me the opportunity to share some insights on the way that NICE does things. But also congratulations to you for building up such a fantastic capability in health technology assessment. I've been asked to talk a little bit about the support provided by NICE to the national health system, but what I'm going to talk about has already been covered by the previous speakers, because there are some very common themes, I think, emerging in the discussions we're having today. Now, most people would know NICE and in the context of health technology assessment as a health technology assessment organisation, assessing new medicines and other technologies, but it does much more than that, and it's always done much more than that. Right from the start, NICE did HTA, yes, but it also covered clinical guidelines, and over the years since it started, more and more was added to its responsibility as the trust and confidence in NICE as an organisation grew, from both the government perspective, the politicians, but also the healthcare system. We were asked to do more and more. And now, if you have a look at NICE's work programs, they cover clinical guidelines, quality standards, yes, health technology assessment of medicines and other new technologies, surgical interventions, public health interventions and policies. So quite a wide range of activities. But again, as Sir Andrew has explained, all of that underpinned by some very important principles that are carried across the organisation. And in the what NICE does, it's been very important for NICE to see itself as wanting to be a trusted provider of evidence-based information. Organisation, but a trusted source of evidence-based information was a really important thing for NICE to internalise, because it set the foundations in a way for the way that NICE then went about its business and the way in which it engaged with the healthcare system and other stakeholders. So that trusted source was vitally important. What did that trusted source of information then mean for the way that the organisation developed? Well, firstly, it had to be robust in what it was doing. So therefore, it absolutely had to rely on evidence and a robust review of the evidence. It had to be rigorous in what it was doing. Individual technology assessments across to guidelines, across to quality standards. That rigour meant the concept of what an evidence base was broadened and broadened, because as you understand the question that the healthcare system wants addressed, you start to realise that maybe the standard evidence base that you would be using from perhaps clinical trials wasn't going to be sufficient. It was necessary, but wasn't going to be sufficient for you to do your job. And that trusted source of information also then started to make NICE realise that it is not just about evidence review, it's not just about health technology assessment, as others have said, as the other panellists have said. The way in which you undertake that HTA becomes vitally important. And that procedural fairness, that procedural transparency, I can't emphasize enough as being of fundamental importance in the way that a health technology assessment body does its work. The accountability for reasonableness is something that NICE adopted really rather early in its development. So not just about the processes by which you undertake health technology assessment and the rest of our work, but how you engage with the stakeholders, how you engage with the healthcare system to understand what it is that it needs, so the topic selection process, how you engage with industry and patient groups becomes vitally important to think about, because you've got, in a sense, the evidence, and then you have a decision. And NICE had to do both of those things. It had to look at the evidence and it has to make the decision based on that evidence. And so the wraparound of the stakeholder input, as we put it, starts to build up a procedural fairness and accountability for what NICE does. And in a sense, that accountability, that transparency, inclusiveness has become part of the DNA of the way that NICE, as an HTA-driven organization, does its business. And as a consequence of that, I think NICE sees itself not just, in a sense, as a gatekeeper of the introduction of new technologies, but an enabler of the introduction of good and cost-effective, so clinically and cost-effective new technologies and other interventions into the healthcare system. So in a way, NICE has built up over the years the viewpoint that it's got to be both very rigorous but also embracing of its stakeholder views in order to be able to do the job it needs to do for the NHS as a taxpayer system. So I just want to hang on to that gatekeeper and enabler concept. The final thing I want to bring in terms of the support that we provide to the healthcare system, and in the context of the trust that we need to have in the way that NICE goes about its business, and the procedural fairness by which that needs to happen, is independence. We've heard the words again, like the other words I've emphasized in other panelists, but independence becomes quite an important component in building up the trust, both of the healthcare system in what we do and what we produce and what we ask them to do, and also the wider stakeholder world. Very, very early, in fact, right from the beginning, and again, as Sir Andrew has pointed out, NICE was established as an independent organisation. That meant that government took the decision at the time that NICE was created to set us up as an independent statutory body and give us the job of both HTA and the policy making, and carrying forward, translating the HTA into guidance, into advice to our healthcare system. That advice from NICE goes directly to the healthcare system. And as a consequence of that, we realized that very early on, that all of the dimensions that perhaps have been highlighted today in the discussions that we've had already are absolutely crucial to the way that NICE goes about doing its business. So it needs to engage with the healthcare system and healthcare professionals. It also needs to engage with all of those other stakeholders. It needs to be seen as fair and independent in the way that it undertakes its business, because sometimes the recommendations are not going to be what the stakeholder community would like to hear. We have to be accountable in being able to justify the decisions that are being made in a simple and straightforward way, so that not just professionals and experts can understand why NICE has said something, but people who use our healthcare system can also understand that. So you can see in this very, very short capturing of what NICE does and how it supports our healthcare system. I've perhaps emphasized some of the things that other jurisdictions have also emphasized in the talks today. It's vitally important that health technology assessment is the bedrock, in my view, of any rational decision making about the introduction of new technologies and the delivery of care. But that's only the start of a process. It's a fundamental building block, but what you also have to think about are all the other dimensions about how you're going to then use that health technology assessment to really make a difference to people's lives, to make healthcare systems more sustainable and more transparent and accountable, and ultimately use the healthcare resources that are allocated in any country in the best possible way. Thanks very much.
Lectures, we could really understand how the support of NICE is being utilized by the NHS and how new technologies and the healthcare system is being strengthened. Thank you.
I now welcome our next speaker, Dr. Tessa. She will be speaking from the perspective of the World Health Organization on the impact health technology assessment has had on healthcare priority setting. Dr. Tessa leads the Unit on Health Economic and Analysis in the Department of Health System Governance and Financing in WHO Geneva. She manages the core work of WHO on costing, cost-effectiveness analysis, economic burden, health accounts, and priority setting. The unit that she leads produces technical guidance and assistance to countries and generates data, including information that's inputted into the Global Health Expenditure Database and the Choice Database, which provides information on choosing interventions that are cost-effective. A very warm welcome to you, Dr. Tessa.
Thank you, everybody. I'm very honored to be here, and I want to say good morning, good afternoon, or good evening from snowy Geneva. I have been asked to talk about the impact of health technology assessment on healthcare priority setting, but I think for all of us here, that is not enough. It is really, we want to talk about universal health coverage. So, health technology assessment, informing healthcare priority setting, particularly what we call allocative efficiency, or decisions which are made on how to spend and on what to spend. But more importantly, that healthcare priority setting decision to be translated into better health outcomes. And for us, universal health coverage is about the health of the entire people in terms of the overall level of health, as well as the distribution of health in terms of equity. There is also a very important part that as people start accessing services, that they do not face financial catastrophe. That is what universal health coverage is. Let me utilize a standard, what we call the UHC cube. And here, this is basically a cube which has 3 axes. One axis is very relevant to health technology assessment. It is the axis on services, which services are covered. But there are 2 other important axes. One is what is the proportion of the costs that are covered when these services are being supplied. And this is what we talk about in terms of financial protection. And the third axis is who is covered, or the population who is covered. And this is basically looking at the equity dimension. If you want to look at this in terms of what it means for India, I would line up every citizen of India, you're more than 1.8 billion people, and then say for each individual, what services does he or she have access to, and for each service, what is the out-of-pocket share that he or she needs to contribute. And if you are able to say in truth that what people, every person in India, every citizen in India has, they have equitable access, then that is what universal health coverage is. We need to understand that this access of services, as we know, health technology will forever be improving with innovation. This is what we want. But this tells us that the goalposts are constantly being reset. And this is why we need health technology assessment. There will be always newer, better technologies. And the question has always been, is it better value for money? So for us, health technology assessment, it is usually the standard language is assessment, appraisal, and recommendation. We recast this in a consistent set of processes that can be applied in any decision. And so we say these are our 3Ds: data, dialogue, and decision. And specifically for health technology assessment, it is producing the data which will inform the criteria that you use for the health, for priority setting. Dialogue is then the application of this evidence plus your value assessments in a very specified way. And then there is the decision that needs to be made. The whole point is really to try to keep the data part of this separate from the dialogue and the decision. And let me go further into this. This part, I think, really has been talked about by the previous speakers, and I think there is no harm in repetition. For health technology assessment to have an impact on priority setting, as well as on population health and financial protection, you can look at each of these 3Ds and see what are the characteristics which will enable it to have the impact that you wish it to have. There should be a systematic application. Dr. Somsak mentioned that, they've been doing this, and many countries in our survey actually say they do HTA or they do HTA-like mechanisms, but it is not a systematic application of health technology assessment. What we would recommend is that HTA be systematically applied in resource allocation decisions in all or most financing schemes. It should be systematically applied within decision-making bodies like the Essential Medicines List, the National Immunization Technology Advisory Groups, in Health Insurance Benefit Board and committees, and I was very happy to hear this, preferably with a legal mandate which requires an HTA to make these decisions. And this is very important that we don't look at it only in terms of what the HTA body will be doing, but actually to look at the landscape, because decisions are being done before. And therefore, there should be a consistency in terms of how decisions are being made for essential drugs, for essential vaccines, for essential devices, for how health insurance decides what the benefits are. So the legal mandate is not just looking at that. What is the legal mandate of that HTA board or mechanism that you are putting together, but really also looking at its position in terms of the landscape of other decisions being done. And hopefully there is a consistency in terms of how HTA will be applied. And what this all means is that we want to try to create a culture which is evidence informed, both on the side of the users of the evidence as well as the producers. The next D is dialogue, and this is really in terms about comprehensive inclusion of the stakeholders. First of all, they need to be informed. You cannot have your patients there if they do not understand what the HTA actually is saying. You cannot also have stakeholders there who might have a conflict of interest. It is very important to have a strict handling of conflict of interest declarations. And equally important is a consistent group process in the application of the criteria as informed by the evidence and in making the value assessments. All of this together, the comprehensive inclusion of stakeholders, the use of evidence establishes legitimacy. It also is what is key in terms of what the other people have mentioned in terms of establishing trust. And together with establishing trust, it is the communication, the transparency, and the documentation that is equally important. And finally, we'll drill down to data, which is basically, I think you already have the basic building blocks for this. The most important thing is a standardized approach. You have different nodes in your network. It is important that they apply HTA consistently. And I think you have, as I mentioned, the building blocks for that through your methodology guides, continuing training, your unit cost database, your health status value. This is to ensure a consistency in the technical rigor and the value assessments. And in doing this, it enhances the credibility of health technology assessments. And at the same time, using a standardized approach through time, through whatever technology, it will promote a level playing field because we talk only about one health budget. The opportunity cost is the same whether you are deploying a biosimilar or a vaccine or a medicine or a medical device. All of them will have the same opportunity cost, which is the health budget of the country, both the public monies as well as the private monies as well in terms of out-of-pocket expenditures. An equally important thing for data is an improved capacity to produce and use HTA. And in looking at this, we consider what is a global good and to consider rapid health technology assessments, making use of the basis on HTA that are available and have been mentioned previously. And as you are doing, to consider work approaches within your states, among your states, and even outside India. And finally, I wish to say, and it has been repeatedly said, having an is the actual implementation where you will have an impact. So the idea is it should go beyond HTA to benefit design. Who actually will benefit from these interventions? That is where the real value for money will come in. And we actually encourage at the moment for many of our low and middle income countries, member states, that an explicit guaranteed set of services be be made publicly available and also known to its population. This is the idea of why do we need a basic set of services when we've been already providing services. Our health system has already been existing, but we all know that our services are not always there. There will always be drug stockouts. Our specialty services, our clinical services, the clinical knowledge, the surgical expertise might not always be there. The equipment might be run down. So when we say a set of services which is guaranteed, it is basically to reassure the population if it is in this list of services, you are sure you can get it with very good quality. You will have the practice guidelines, you will have the drugs, there will be supervision, and there will be monitoring in the provision of these services. So in a way, it is to ensure accountability when you have an explicit and guaranteed set of services. Everything else, all the other services in the health system can continue to be provided, but for a focused set of services, that is where you will say this is guaranteed. And finally, for HTA to have an impact, please remember you have to set up a mechanism to monitor the impact from the start. So these are resources available from WHO. I would just want to point out one, which is institutionalizing health technology assessment mechanisms. This is a how-to guide. We have an entire chapter there on legal mandates. And the final chapter there is how to monitor impact of your health technology assessment. As a final word, I just want to say, as has been mentioned by Dr. Vinod Paul, you are past the baby stage already. You have finished taking your baby steps. You have set up the infrastructure. You are just about to get your legal mandate. Sir Andrew Dinon of NICE has said it took them 20 years to get to this point now. I honestly believe that India will not take 20 years to do this. It will move very fast. It will take giant steps, learning from everybody else who has spoken here and from all the rest of the globe. We in WHO would want to be with you in partnering with you in this process from our country office all the way to Geneva. And we are also very happy to see your partners here from Thailand, from IDSI, from NICE. And we would like to really be part of this movement towards a very important, I want to just quote Carol, it's not about HTA, it is really about being a trusted source of evidence-based information for resource allocation decisions. Thank you very much, and I will be available for the Q&A. Over.
His areas of expertise are economic evaluation, health financing, health sector priority setting, indigenous and global health issues. He has worked with governments both in Australia and overseas, and with international agencies such as WHO and industry. He has a strong interest in training and organizational capacity building in HTA and is currently involved in projects in China and India to investigate the translation of HTA evidence into government decision making. He was also a member of the Lancet Task Force on NCDs and Economics. Welcome to Professor Stephen Jan.
Everyone. I think I had a recorded presentation, but I'm happy to present it again if that's the arrangement. Hi everyone, my name is Stephen Jan. I'm Professor of Health Economics at the George Institute for Global Health, University of New South Wales in Australia. And many thanks for the invitation to present to you today. So the topic of my presentation will be on the impact of HTA on health policy in Australia. There are three aspects to this presentation. I just wanted to firstly cover or describe the HTA process in Australia and talk in particular about the history of the HTA system and how it's developed over the years. Second, the objectives of HTA, particularly in the Australian context, and thirdly, the policy impact it's had. So HTA in Australia generally recognised to have been established when the Pharmaceutical Benefits Advisory Committee in 1993 mandated the use of cost effectiveness for the listing of new drugs onto our benefit scheme. So this is probably the first jurisdictions in the world to do so. Just as a comparison, I think NICE was established in the late 1999 and so late 90s and brought in their own HTA process in the UK around that time. So I thought I'd throw that in there, given that Australia is currently playing England in cricket. What distinguishes the HTA process in Australia is it's an adversarial process. It basically has on one side submissions that are sponsored by industry and submitted by them to the PBAC, the Pharmaceutical Advisory Committee, who then review these submissions, and there's a process of negotiation and then hopefully finally agreement over price and cost effectiveness and then finally access to markets. So before this process is initiated, new drugs initially have to go through the Pharmaceutical Goods Administration to assess for safety and efficacy. And this is a committee that enables the drugs to initially enter the market. The PBAC then comes into play when manufacturers want to list the drug for a public subsidy. And the criterion that the PBAC uses, as you expect through its HTA process, clinical efficacy, cost effectiveness, and budget impact. So just a brief description of the HTA or the PBAC process. Generally, PBAC sets out 17 weeks to assess a submission. That involves, firstly, the submission coming in from industry, an initial review by an evaluation group, usually an academic group. So there are a number of these academic groups around Australia. They've been commissioned by government to review these submissions, provide a report. The sponsor then gets a chance to respond to these reports. These, the review, the submission, and the response then goes to the economic subcommittee, which is an expert committee that then reviews the submission, the evaluator's comments, and the sponsor's reply, and then in turn provides a report. That report then goes to the PBAC, who then make a recommendation. That recommendation then goes to the minister, who then makes a decision. Importantly, by law, the minister can't list any new drugs that have not been approved by the PBAC. The minister can, however, reject a drug that has been recommended by the PBAC, and these are important legislative provisions that I'll come back to later. Describes what I just told you. I won't go through it again, but I've left it in the slides in case you want to have a closer look later. So what does the actual health technology assessment involve? What does the submission actually involve? Well, in Australian guidelines, there are 6 sections, and these are probably familiar to you if you're familiar with the HTA methodologies. The first is details of the proposed drug and its intended use. Then there's a clinical evaluation. Then there's a section that translates the evidence that we get from the clinical evaluations to the local setting, which enables us to then use that evidence in the economic modelling. Then there's the section D, which is the economic evaluation. Then there's a budget impact analysis that looks at the extent of use and financial implications. And then finally, any relevant information that the sponsor might have that might support the application. So in terms of objectives of the PBAC process, the overriding objective is enables governments to invest in new drugs and technologies that cost effectively deliver health gain. So that's ultimately what the government aims to do. But in terms of the various players, and there are other things that the HTA process also achieves. Firstly, it enables government to leverage its power as a single purchaser to access medicines and technology at a reasonable price. Secondly, for industry, I think industry also benefits from the HTA process in Australia. It gives them a clear pathway to market at an agreed price. For consumers, it provides universal access to medicines and technologies. The fourth point here is a question mark a question that I raise is whether it saves money, and that's often a bit of a perception that some people have of the HTA process and the use of cost effectiveness. And I'll just show you a slide here that debunks that notion. You can see here, this is expenditure on the Pharmaceutical Benefits Scheme from its inception in 1948 all the way up to the mid-2000s. And you can see there's an increase all the way up to around 1993 when the PBAC mandated cost effectiveness. So there was a bit of a drop in the years following that, but subsequent to that, there's just been a steady and increasing expenditure. So it really hasn't contained healthcare expenditure, and I would argue nor that should it, or was it ever the intention to contain healthcare or save costs. It was more about delivering, as I said earlier, delivering health gain cost effectively to the Australian population. So just so that sort of gives leads us to a broader issue around the impact of the HTA process has had on health policy. And to sort of explain sort of this impact, I want to dichotomize HTA models around the world into two different categories. These are categories that are sort of made up, and so, well, I mean, be keen to get your thoughts on that. The first is what I call a soft model, and that's where HTA basically acts as an advisory body that provides evidence. It's independent of government, and government has no sort of obligation to take up that advice. Then there's a hard model where there's regulatory or legislative backing for the HTA process, and that happens in Australia. As I mentioned in an earlier slide, there's in some ways it supersedes the role of the minister in making decisions about the listing of new drugs. And I would argue that the hard model works better. And the general reason why is that it enables government to credibly commit to a due process. And I'll explain this point in this next slide. So the fundamental problem that HTA is aimed at addressing is that when we're making investment decisions about new drugs and new technologies, there are numerous vested interests involved. They're industry, consumers, bureaucrats, healthcare providers, and program managers. HTA offers an unbiased process that generates recommendations based on evidence. So without the HTA process, or where a HTA process just provides recommendations without any sort of commitment to using those recommendations, decision makers have discretion to ignore that advice. And the more discretion they have, the more subject they have, the more they're subject to interest group pressure and this notion that we have in economics called regulatory capture. So in a sense, there's a paradox here. By empowering this, you can empower decision makers by restricting their discretion through some sort of pre-commitment to an arm's length decision-making process. And that's described earlier with the legislation that we have in Australia. And this is achieved through, a hard legislatively based model that we have over here. So that's generally the point I want to make about HTA and its link to policy, that fundamental sort of legislative backing is really important in increasing the effectiveness of a HTA system. In Australia, there's been a recent report that sort of highlights some future directions for HTA. I'm not going to go through them all. I've just listed 4 of them here, and you're welcome to get back to me, and I can sort of pass on details of this report. But before that, I thought were interesting were looking at codependent technologies rather than just individual drugs or devices. So increasingly there's recognition that certain technologies belong together in a package rather than as individual entities, and it's important that health technology assessment methods and processes are adapted to enable us to assess these. There's also a movement to establish an Office of Clinical Evaluation within the Ministry of Health to assess not just pharmaceutical interventions, but non-pharmaceutical interventions. And I think that'll be a big step forward in the Australian system. There's another process underway to streamline the Life Savings Drugs Program to provide it with a slightly different pathway to all other drugs in the system. I'm a little bit ambivalent about that, maybe something that we can talk about later. And finally, a point that I'm really sort of keen on is that there's strong interest in addressing the shortage of health economists in the country. So I'll leave it at that, and I welcome discussion and questions from the audience. Thank you.
Interesting, insightful. We will take up, due to the time constraint, we will be taking up only few questions. We've taken up some questions from the chat box. So we will go to the question and answer session. The first question is, in a multi-payer system like India, how HTA can facilitate the clinical decision-making for costly interventions where the choice of treatment is mainly decided on the basis of paying capacity of patients? We would be very happy if Professor Dillon can help us answer this question. Professor Dillon?
Hi there. Well, yeah, it's an interesting question. Actually, I don't really think it matters who's paying, whether it's an individual or an insurance company, or whether the services are being provided by the state. In the end, what matters is what value does a particular choice for a form of treatment or a kind of service bring to individual patients. It's essential wherever the money comes from, that value is consistent with whatever is being asked in the way of payment. So in India, a system which is complex and diverse, certainly compared to the rather simple universal healthcare system that operates in a much smaller UK system. Very diversity, I think, argues for a single source, so that there's consistency in the judgments about the value to patients of an individual taking, and whether or not that choice represents good value for them.
Thank you so much, Professor Dillon. We have one more interesting question. We had a nice presentation by Dr. Tessa. Tessa spoke about the 3 Ds, dialogue. So there's a question on what role can be played by private market forces towards institutionalizing HTA? This is a big question that we are still asking ourselves, and we don't know the answer. We would be very happy if Dr. Tessa can help us.
The actual question is, what is the role of private market
forces towards institutionalizing HTA?
Okay. I think there is a place for all stakeholders to participate in the institutionalization of HTA, but there is an appropriate place for each one. I think one of the key characteristic of an HTA body, which has been repeatedly stated by many of the speakers here, is the independence of the process. I do not think we are politically naive in here, and we say that every stakeholder has its agenda. And the agenda of the private market forces, although would be, you could look at it in a more positive way in terms of enabling innovation, there is still their primary audience, which is really their stakeholders, their own stakeholders. So as long as those interests coincide, and as long as we are not politically naive, then they can have a place. But what is important is the HTA body should put in the boundaries, should put in the ring fence in terms of how much influence they can have in the actual evaluation and in the actual production of evidence and in the evaluation. They will always be there. They need to be there. However, they have an appropriate place. And the way that we can ensure this is to make sure that our processes are in place to handle all of this different agenda and to make it really transparent and to document this. Over.
Thank you, Dr. Tessa. That was a nice one.
So the next question is for Dr. Somsak, and we have a question here that sometimes clinicians and key stakeholders may not agree with the recommendations that come out from an HTA report, especially when it's at odds with existing clinical practice. And if you can share your experience and how you've managed to negotiate with the different stakeholders if such a situation arises.
Hear me? Yeah, thank you for the question. I think it will be a very complex process, but I'll just give you some idea. As I mentioned, for the so-called manufacturer of the commercial sector of pharmaceuticals or different technologies, there's a so-called price submission and price negotiation process. So the negotiation is there. The other thing is about the participation or parity setting. So we hope that the process of selecting things to be assessed as well as negotiating on the final outcome would accommodate the concern and the so-called giving the pharmaceutical company or commercial sector some voices. On the clinician, it's something different because I think clinicians always say that technology assessment would encroach on their autonomy. But as you can see from the way we apply, we didn't encroach on physician or practitioner autonomy to make decisions for individual patients. But as the previous questions was about patients' demand for new technologies, in Thailand, there's always a room for that. In other words, if they would like to demand for new technologies. But the fact is that if we make reasonably good effective technology as a cost effective as well, available in a so-called collectively financed systems, it's up to the patients to choose. And a physician never practice in a particular context. They always practice in a so-called multiple possibilities, so they can try to convince the physician, the patients that, you have to have this technology, in other words, and you need to pay more. Of course, it's up to the patient to decide. So the autonomy is never controlled by the technology assessment results. The technology assessment result is used decision. You have to engage the patients in that particular process. And again, back to the point that if the system is already making reasonably good technology available, Then it's up to the patient to decide whether they would like to pay more. The moment that you make the system outdated, that's where the things would be a bit more complex. But again, in terms of autonomy, that it was not encroached or controlled in any way by the technology assessment process. I hope that clarifies.
Can someone check? Okay, now it's on. Okay. So my next question, Professor Stephen Jan wanted to request if you could respond to this. And this question is regarding data, and that often, especially in LMIC setting, while we are working towards setting up infrastructure for collecting reliable data, we, while doing the analysis, may not have all the data that we require to conduct it. So if you could share your experience regarding this and any advice for some young researchers in the audience on how they can make progress.
No, I don't think that's a problem that's confined to LMICs. I think it's inevitable when you're doing economic evaluations and economic modelling that you're working with imperfect data. And in fact, that's the reason why we do the cost effectiveness modelling, is to augment the data that we have to enable us to predict outcomes that we can't actually observe at the present time. Having said that, I think India is making some very good progress in improving data sources. And I know, for instance, my colleague, Professor Shankar Prinja at PGMI Chandigarh has been working on developing a number of resources and access to data sets, particularly around costing. And that's a public good that is potentially going to be really useful. It's developing of these resources and these data sets that are ultimately going to enable us to improve. But yeah, as I said, the general answer to the question is economic evaluation. Basically, there are ways in which you do analyses that take into account imperfect data. There's modeling, sensitivity analyses, those sorts of things that ultimately need to be employed, and they're all embedded in the HTA methodologies.
Thank you very much. Thank you. And just for everyone to also inform them that Professor Stephen Jan is referring to the National Health System Costing Database, which is soon going to be updated with data from a study which was commissioned by the Department of Health Research, the Costing of Health Services in India, which has data across 11 states, both public and private hospitals. And soon it's going to be a public good because it's going to be available in a digital format for researchers and policymakers to use. So thank you for sharing that. I have a question for Dr. Javier Guzman, and this is more a policy level question in terms that in Indian health system, no, I was waiting for you to come to the dais. Yes, so in the Indian health system, we have a very strong private sector, which is not necessarily very strongly regulated. And the majority of the expenditure is out of pocket, with 70% of the expenditure being out of pocket. So we don't have a single payer system like other countries like UK or a very big UHC scheme like in Thailand. So in this scenario, how can HTA still be a useful tool to help the population make the right choices and to help them decrease the out-of-pocket burden? Any advice from your side?
I think it is not an easy undertaking, mainly because, well, first, we're talking about patients that will need to be aware of the importance of evidence. So I guess there's a lot of room to communicate, why evidence is needed, why, effectiveness is crucial, and why the shiniest, latest, brightest, newest technologies are not always the best technologies. But I think that's a difficult undertaking, one patient at a time. I guess a good way forward is, one, to work with the private providers to optimize their services in terms of quality and to make that offer evidence-based as well. And for that, clinicians, and I think back to the question on, autonomy, clinical, medical associations do play a big role, because HTA is also part of, should actually be part of clinical practice, determining what medicines should and should not be prescribed, in what cases, what populations, at what cost. So I think there's work to do with the patients, there's work to do with the clinicians, with the medical associations. But I think the biggest possibility in a multi-payer system like India is to basically identify, the biggest payers and link them, identify, the biggest producers. That formal linkage between users and doers is a very important way forward, partly because it's not enough, as I was saying, to just produce evidence. Unless the linkage is formal, unless the relationship is there, and unless there's the mandate, the users will basically might not act upon the evidence.
Thank you. That's very valuable advice. Linking the generators of evidence with the big users, looking at some of the earlier programs that we heard, the Ayushman Bharat program, linking it to actual financing and implementation in the country. Also to share that Dr. Javier mentioned about harnessing the professional associations, and a very good example in India is the National Cancer Grid, which uses rapid reviews of technologies, uses rapid pragmatic methods, and then links them to clinical guidelines, which are used by practitioners, not only oncologists in the country, but 60% of cancer care is taken care by them, but also links with the benefits package of cancer in Ayushman Bharat. So thank you. There's one last question for Professor Carroll, so inviting Dr. Kavita.
As an extension of what Dr. Abba was speaking, we would like to know from Professor Carol Longson, if there is the evidences, how do they support in designing the standard treatment guidelines? You also mentioned about social and mental care guidelines, because these are going to be new things that India would like to look upon and start it also through.
That's a very good question. But again, start from the principles of using evidence in order to inform decisions. So the approach that NICE takes to both clinical guidelines and the other non-specific health technology assessment programs is very similar to those standard health technology assessment programs. A synthesis of the evidence, meta-analysis of trials, defining the questions, the key questions that you want to address of that clinical pathway or the patient group. And particularly tricky, although achievable, doable, is undertaking health economic evaluation in a guideline context. So all of the building blocks of health technology assessment are applied in those circumstances to clinical guidelines and other types of outputs that are non-standard HTA. But one of the issues is the context in which you're doing that is very different when you're looking at individual health technology assessments. The context is the uncertainty around that evidence is much higher. So that link between understanding uncertainty and probably using the stakeholder group that you have, particularly the clinical community, and also the patient community, those with lived experience, to in a sense, try to interpret the evidence under conditions of uncertainty in the context of best practice has become quite an important component of the way that NICE undertakes clinical guidelines development. And it's become probably one of the most important learning lessons that we have had. In a sense, the evidence only takes you so far when you've got a much wider context to consider, like a clinical guideline. You need to have the inputs and the active interaction of the stakeholder groups.
Thank you so much. The International Symposium of Health Technology Assessment has been a strong platform for knowledge sharing between nations, a day that has shown a way to spread the power of HTA in the right direction for supporting universal health coverage. With this, I stand here to propose the vote of thanks. I thank every speaker who has brought in their knowledge, translated that into our vision, and this vision will be taken forward in fulfilling the vision of India to have universal health coverage. I thank all the speakers who have joined virtually. I also thank the speakers, Dr. Somsak and Dr. Javier, to have taken out their time to bring and to have their presence in India. This is also a time that I would like to thank our Minister, HFM, also the Minister of State, who have taken out their time and always supported of HTA to make it into a big player for helping them in bringing out universal health coverage. Professor Vinod Paul, Member Niti Aayog, Chairman, MTAB, who has also been a guiding light to actually chalk out the right path as a visionary to bring HTIN to the highest rim in India. We have Professor Balram Bhargav, the man of the year, who has always been a driving force for all the new initiatives that have started in DHR, ICMR, and he has pinned every impossible challenges into a possible way forward. We have Madam Anu Nagar, always with a pillar of support for HTIN, and her encouragement has made this day a fruitful day where many people could hear it, listen it, and feel how HTA could help them in universal health coverage. I thank all the event management team, the DHR team, the HTIN team, the IDSI team. IDSI has been a support for us right in 2016 in actually bringing out such international practices into Indian knowledge. We thank the IDSI team. I also want to give a special thanks to my HTIN and the IDSI team, Dr. Abha, Dr. Kirti, Dr. Amir, and Dr. Malkeet. Not to say all the others have supported us in small and in big way, but to end the talk, special thanks to every participant who have joined us virtually, participants who have joined us physically. Before I end, the 2 books that have been released are being, as a PDF format, have been placed in the pen drive that is there in the folder. People who have joined virtually, it will be uploaded on the DHR HTIN website for them to look into the 2 books that have been released today, including the video. With all these things, we call for all of the participants and the dignitaries on stage to join us for a high tea in the Nalanda Hall. To the virtual participants, we thank you all for your patience, perseverance in listening to this. Without you all and the speakers, the program would not have been a success. Thank you to all.
Inviting you all to please join us for high tea. It's downstairs. You will have to take the steps of probably the escalators. Please join us for high tea. Thank you.